targeted therapies for metastatic breast cancer, or cancer that has spread from the breast to other organs of the body, are helping patients live longer with fewer side effects.
Breast cancer experts will join us on this week's Health Talk to discuss the latest treatment options for patients with metastatic breast cancer.
So stay tuned, we're up next. Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazer. We're joined today by Dr. Linda Vedot and Dr. Richard Zelkowitz. Dr. Vedot is Director of Cancer Services at Norwalk Hospital, and Dr. Zelkowitz is a dear friend. He's also Medical Director of the Smilo Family Breast Health Center at Norwalk Hospital. Welcome, both of you.
Thank you very much.
Linda, great to have you here.
As you may have heard, Norwalk Hospital and Memorial Sloan Kettering Cancer Center have just announced a new cancer care collaboration that will integrate MSK medical and radiation oncologists and care practices with the existing cancer programs at the C. Anthony and Jean Whittingham Cancer Center at Norwalk Hospital.
So Linda, this is a very exciting collaboration. Tell us how this collaboration is going to work.
Well, we're incredibly excited to have partnered with Norwalk Hospital. One of the things that I want to mention is that, we've actually been collaborating for many years. Now this just really formalizes our partnership. What we're doing is that we are basically taking a great cancer center and we're making it into a world-class cancer center, leveraging the tremendous resources of Sloan Kettering into our community here in Connecticut.
So that means that patients who used to travel to Sloan Kettering can get at least some of those services here at Norwalk?
Absolutely. Now we can get access to world-class treatments, therapies, therapeutics in our backyard.
Rich, I know you've been going to Sloan Kettering as long as I've been here, over 20 years, just 25 years.
Since
maybe
1995.
Maybe longer than that. How does this change things for you?
So for me, it just continues to reinforce what I like to think we've been doing for the past 20 years and have a real give and take. We've sent patients down there for options that are not available locally, and for things that can be done in the community, they've been sending patients back. So I think that it won't probably change it a great deal in the breast world because we've been doing it, but for the rest of the cancer types, I think this will really increase the options patients have.
What a great opportunity. Really wonderful.
So our doctors will be collaborating, or I should say the MSK doctors here at Norwalk will be collaborating with the MSK doctors in New York on a regular basis and using similar treatment protocols. And
absolutely. MSK physicians at Norwalk will truly be MSK physicians with access to the educational, the research, as well as the treatment modalities.
So even for a second opinion, they can get that here at Norwalk and know that the full resources of MSK in New York are behind that opinion.
Absolutely.
That's very, very exciting.
Yeah, I think what's unique about this is you hear about a lot of these associations, but this is a real association.
Yeah.
The docs are here. Our docs are going to be there. So it's more than just advertising.
Yeah, this is
it's
really
the real
very,
deal.
very substantive.
Yes.
See, and as you said, our docs will be routinely participating up there in case conferences and discussions about patients and protocols, and there are actually certain physicians that have been added. I guess, Linda, you've joined us here in Norwalk, is that right?
Yes, I will be taking care of breast cancer patients and joining the tremendously fabulous breast cancer team here at Norwalk Hospital. So I'm really looking forward to it. And
you've got a lot of competition.
We're not competition.
We're not competition.
We're colleagues.
We're colleagues.
We've actually been working together for about 20 years, taking care of patients. So this is just an extension of what we've been doing.
Sort of formalize that.
Yes.
And Rich has been so involved in some of the research projects that we've been doing that he's actually listed his authorship on a couple of our papers. So just really, this is just the next logical step in our collaboration.
And I think that just represents excellent medicine. I think no physician practices in a vacuum today.
Right.
And utilizing the expertise of all those around us on a regular basis. And what better expertise to be able to assess, to avail ourselves of than those people at Sloan Kettering. It's really the world-class cancer center.
Yeah, and it's one of the oldest cancer centers in the U.S. They've really led the way in not only research and treatment, but also patient-focused therapies. And many of the resources that they have will be able to adapt what works for us here up in Connecticut. And I think we're all really excited for that.
Yeah, I think every doc who is committed to their patient is always going to try to make things better for the patient, keep themselves stimulated, and this accomplishes all of that.
That's wonderful.
And my understanding is that patients may come and see you here if there is a service that we need that is not available here, some exotic surgical service or something like that, they will then be referred up to the Sloan Kettering in New York City. Is that right?
Correct.
That's very, very exciting. Wonderful asset for the community. And as you said, really a substantive affiliation that's very meaningful for the patients.
And as you mentioned, you're joining in our community a wonderfully robust breast cancer treatment program and center already. And maybe you can tell our viewers a little bit about metastatic breast cancer, just even starting off with what that means.
So metastatic breast cancer is when breast cancer spreads outside the lymph nodes in the neck. And it's usually considered a highly treatable disease, but usually you can't get rid of it forever, so you always need to be on something. And one of the things which I think characterizes a lot of the research that we've been doing over the past decade is that we've been able to have patients live longer and live better with so many of the new therapies that are coming out. And it all really comes down to the fact that we understand the disease so much better. So while patients still have breast cancer that spreads, I think we're managing a lot better. But of course, I would challenge everybody that we have to find out why it spreads and prevent it from spreading. So we don't really have to talk about metastatic breast cancer.
Is there work going on to prevent the spread? And are there some new exciting techniques or drugs that are helping in that respect?
There are a lot of brand new techniques and a lot of brand new approaches towards preventing the spread of breast cancer. When I think about the thing which has really revolutionized how we've thought about breast cancer has been the advent of drugs that target something called HER2/neu, which is a growth accelerator, which is present on about 25% of breast cancers. And we know that if patients get a drug called Herceptin, that it will make them live much, much longer. And what it does is it cures the vast majority of them, as opposed to in the past, the vast majority of them would succumb to their disease. So I think that that's probably the biggest advance that we've had in preventing the spread. And there are other drugs now. There's a drug called pertuzumab and another drug called neratinib, which can also help to prevent breast cancer from coming back. And then there's another strategy, which we've done a lot of research in, looking to pull out the infrastructure the tumors need to spread. And that's, we've done some work in that arena, and I won't go into it too much. Rich, what do you think?
But, Linda's being modest. She has done some of the landmark work on the bone marrow microenvironment and published data on copper, which we've been able to participate in to sort of better understand what causes metastasis and then prevent that. We also have learned that we can do that with certain common drugs like bisphosphonates, which we've given for years for women to prevent osteoporosis, which has also shown to reduce the risk of breast cancer recurring. And that's always our goal. While we always want to have better therapies and less toxic therapies, if we can prevent things from recurring, that's always the best thing we can accomplish.
Just for folks at home, I think a lot of people get confused by the idea of metastases. Breast cancer is breast cancer even when it spreads to the bone. It's not bone cancer.
Right.
And that mistake is often made, I think. And so these treatments really are focusing on breast cancer that is either spread or has been contained. Contained we can cure. Do you think we'll see the day when we're able to cure metastatic breast cancer using the new therapies?
Absolutely. I have no doubt about that.
Maybe you could say a few words. There's been a revolution in cancer. I think it's been a silent one because people don't understand it. It's a little bit harder to explain, but there's really been a revolution given that we now understand many, if not most cancers at a molecular level, which has led to a flood of new drugs. Maybe you could say something about that.
So while we do understand tumors much better at a molecular level, it's probably not just understanding the DNA makeup and targeting what they call driver mutations, the engine that makes tumors spread. It's probably going to end up being a combined approach. And as Rich alluded to, we've done a lot of work in terms of what's called the tumor microenvironment. So the thing is, tumors don't travel with their own infrastructure. What they do is they hypnotize and they co-opt, normal cells to do their dirty bidding, to spread. And there are a lot of strategies out there, as we mentioned, with our copper depletion approach that basically pulls out the infrastructure the tumors need to spread. So that's probably just one way.
So it poisons the garden that they try to grow in.
Well, it's sort of like if you think about it, a tumor cell as a car, and think about the microenvironment as the gas. It's so like the car has no gas, and so it's just sort of sitting there, all dressed up and nowhere to go. And that's just probably the tip of the iceberg in terms of, affecting the microenvironment, because there's the immune microenvironment.
I was just going to mention that.
There's, there are many different components of the microenvironment which contribute to tumor metastasis. So I think while genomics and DNA and understanding that is incredibly important, I don't feel it's the full story, and we're just sort of starting to investigate those other parts to the story.
It's so exciting, and Rich, it seems that the tempo of new discoveries and new drugs being developed has rapidly increased in the last few years, so that for patients with many cancers, something new may be right around the corner, whereas that might not have been so much the case a decade or two ago. Is that true?
I think that's very true. I think that also speaks to the need to subspecialize in what you do, because things do change so quickly. In estrogen receptor positive drugs, drugs that are sensitive to estrogen, we've got a whole new array of drugs, and we've identified techniques to find other markers with drugs following. Dr. Vedad talked about the HER2 positive patients, so we've just had an influx of drugs in that area. So I ultimately would like there to be no more breast cancer, but I would certainly speak to the possibility of eliminating metastatic breast cancer.
And I think that you made the point, that's the point of 30 years ago, I practiced general oncology. We took care of all kinds of cancer, all kinds of hematologic disorders, and given the pace of discovery, we really do need to see specialization within the oncology world right now, and we're providing that here at Norwalk, aren't we?
Yeah, I believe in that very, very strongly. That's been one of my mottos since I've been here for almost 30 years. I think that's really takes our level of care to a higher level.
And Linda, we have a little under a minute left, but can you talk a little bit about what's it like to be a doctor who now has so much more to offer someone who may hear some scary words than perhaps you had to offer them even just a few years ago?
I think it's one of the worst things you can ever do is not tell people that there's something you can do for them. You know, they can always decide if it's something they want to pursue based on side effects and likelihood of success, but I think if you say there's nothing you can do for them, I think it's like the worst thing that could ever happen, you know, as a doctor, and certainly as an oncologist. You know, this conversation reminds me of a situation I had recently where I take care of a young woman who has metastatic breast cancer. It's a HER2 positive breast cancer, and and about a year ago, I was so worried because, oh my gosh, what am I going to give her next? What am I going to give her next? And today, a year later, she's doing fine because we've had at least 2 brand new drugs which she can participate in. One of them is a very good antibody drug conjugate that she just got on a trial. She's doing great, you know, and so I mean that just gives you a sense.
It's fabulous, and that really reflects the oncology in this decade. It's just the rapid advances that are being made, and so that there's always some hope out there that's very meaningful and not perfunctory. Unfortunately, we've run out of time. I want to thank our guests, Dr. Linda Vedad and Dr. Richard Zelkowitz, for joining us on Health Talk today.
Thank you both so much, and thank you to our viewers for watching. Please do remember to send us your questions and comments to healthtalk@wchn.org.
And Jude, I'll see you next time.
Stay well.